Inicialmente los quiero saludar a todos. Un gusto que estemos nuevamente aquí entre todos participando de este webinar. ¿Se me escucha bien? ¿Sí? Yo no los veo porque está la presentación, pero cualquier cuestión me avisan. Bueno, nada, solamente eh, mencionar 2 o 3 cuestiones en relación a esta charla. Como ustedes saben, el mes de abril es el mes del Día Mundial de la Hemofilia, que es el 17 de abril. Y es entonces en ese marco que nosotros definimos y quisimos avanzar con una actividad que es una campaña continental vinculada al tema de la hemofilia, a los fines de darle visibilidad, ponerla sobre relieve y que la comunidad en general pueda participar de las acciones que hagamos y también difundir fuertemente, porque ese es uno de los grandes propósitos que tenemos en la organización con este tipo de eventos. Y es en ese sentido que eh, pautamos hacer 3 actividades de webinars, de charlas virtuales, vinculadas a lo que tiene que ver con acceso y tratamiento de la hemofilia en el continente. ¿Esto cómo se traduce? Se traduce en 3 charlas, que es esta inicial que estamos dando hoy, con la doctora Margareth C Ozelo, que, que habla sobre terapia génica en hemofilia A y en hemofilia B. La semana siguiente, el día 9, vamos a tener la charla que va a dar el doctor Miguel Escobar, que es vinculado a terapias de no reemplazo de hemofilia. Y luego vamos a tener la otra conferencia el día martes 16 sobre los tratamientos que son de reemplazo de vida común y vida media extendida y otras coagulopatías también incluidas en estas sesiones, que eso es el día 16. Para cada charla se tienen que inscribir, ¿sí? En sí misma, en cada charla no se inscriben a las 3 webinars, sino los que se inscriban a esta y quieren participar en las próximas, se inscriben en las próximas también de manera independiente. Seguramente a todos ustedes les ha llegado seguramente un mail en el día de hoy, donde ahí van a tener las sesiones siguientes, así que van a poder también registrarse para las próximas. Pero bueno, les quiero agradecer también, en este caso a Biomarin, a Kedrion y a Pfizer, que colaboraron y les pareció interesante y significativa esta campaña con estos 3 webinars y todo lo que hacemos luego en redes, que apoyan esta iniciativa. Así que les queremos agradecer también a ellos por esta confianza. Y bueno, sin más preludio, quiero presentar a la doctora Margareth Ozelo. La doctora Margareth Ozelo es hematóloga, se dedica específicamente a lo que es terapia génica en hemofilia. Ella está en la Unicamp, en la Universidad de Campiñas, en Brasil. Tiene realmente un currículum muy largo y muy importante, pero tampoco quiero ser tan extenso, pero por lo menos sí mencionarle que es la referente, sin ningún lugar a dudas, en América Latina y Caribe, vinculado a hemofilia, por la cantidad de protocolos, de trials y de investigación que ella va llevando adelante en terapia génica en Brasil, en la Unicamp, como les decía. Vasta experiencia en hemofilia, muy reconocida a nivel internacional, va a estar en el Congreso Mundial de Madrid, también dando temas vinculados a estos, así que la verdad que, primeramente, es un honor para nosotros que usted pueda estar, doctora Ozelo, y sobre todo agradecerle este rato que nos cede, que nos presta para que toda la comunidad de pacientes de las Américas pueda justamente conocer un poco más sobre lo que es terapia génica e incluso algunas novedades. Sabemos que, no quiero adelantar mucho, pero sabemos que hubo alguna novedad sobre Anvisa hace poco y me parece que también es interesante que marquemos y que sepamos que hay avances en la región en ese punto. Pero bueno, principalmente sobre todo los conocimientos y los protocolos y experiencias que usted va teniendo en la Unicamp con esta terapia, ¿sí? Así que nuevamente agradecerle el tiempo. La idea es que la doctora exponga y después haya preguntas en el chat, a los cuales entre Andrés, Marta e Isidro, bueno, coordinadores de la coalición, entre todos vamos a ir recopilando y les vamos a ir haciendo a la doctora para no abrumar de tantas preguntas que seguramente las va a ver. Así que bueno, no le robo más tiempo, doctora, le cedo la palabra muchas gracias por el tiempo y por participar, como siempre.
Okay, muchas gracias. Well, unfortunately, as Antonio said, and the very nice words, I'm from Brazil. I'm here in Campinas. And unfortunately, still not speaking Spanish. So instead of to be Portuguese, we decided to speak in English here. But I know that there is a simultaneous translation for who wants. So, Antonio, if you can share my presentation. Well, first of all,
ahí Isidro, les quiero recordar, como dijo recién la doctora, todos tienen que elegir la opción de un idioma de interpretación, español o inglés, y no quedarse en el que dice solamente audio original, sino que elegir siempre un idioma, ¿sí? Así que, perfecto, avancemos entonces.
Okay, thank you. So, well, first of all, thank you for this great invitation and nice words. It's a pleasure for me to discuss here about what is the updates, the current news related to hemophilia A and B gene therapy and the challenges for our region. So next, please. Next slide. Yeah, so you are probably familiar with the alternatives that we have for the treatment for hemophilia. So for years, actually for decades, we use replacement therapies with concentrates of factor 8 or factor 9. And even more recently, we have the extended half-life factor. And in this case, we always have the peaks and troughs, and this being a standard of care for years, and it is a very good treatment for these patients. So more recently, we also have the non-factor therapy, such as the mimetic therapies as emicizumab, and very soon we will have the other non-factor therapies that is related to the new rebalance of the hemostasis. And we also have the gene therapy. The difference here in the gene therapy is the ability to produce your factor 8 or factor 9. So we have endogenous factor 8 or factor 9 with the goal to reach the hemostatic level, especially if we can reach the normal or at least the mild level for hemophilia A and B. So if we're thinking about what is the main objectives of the gene therapy for hemophilia, we are looking for a treatment that's giving us a sustained long-term factor expression that achieve optimal therapeutic levels. So to convert as a normal level of factor 8 and 9, with that avoiding all bleeds. And we are also looking for gene therapy, a way that we have consistent results and predictable outcomes. We can say to the patient, okay, if you have this treatment, we will achieve this level as what we expect. Also, we wanted to provide a safe treatment and decrease the treatment of the burden and to reach what we call now hemophilia-free mind. And this treatment should also give us some evidence of cost effectiveness, because we are know that this is a new technology and with some challenges related to the cost. So next, please. So if we consider all the advanced gene therapy for hemophilia, up to now are using the same strategy that is using adeno-associated viral vector. So it's AAV-based gene therapy for hemophilia. And in this AAV vector, we have the transgene that could be the factor 8 or the factor 9 gene. And once we have this vector, we, through an intravenous infusion, we can reach our target cells, that in this case is the liver cells, the hepatocytes. And the hepatocytes, they receive this vector with the transgene, and then we will have in the nucleus of the transduced cells the code, the transgene of factor 8 or factor 9 DNA, and with that we started to produce the factor 8 or factor 9. Next, please. But all the time that we use this approach, this strategy, adeno-associated viral vector, we also have a main challenge that is related to the immunogenicity related to this vector. So next. And one is related to the pre-existing immunity. That's because the adeno-associated virus we can actually found in the nature, in the environment. And this doesn't cause any disease. And many times we can be exposed to this virus, and many times we can also develop some immune response to that. So we can actually produce some antibodies that can recognize this AAV, this adeno-associated virus. Well, when it comes to use this backbone of this AAV for the gene therapy, many times we can have, in some cases, cross-reactivity of the antibodies that we may have that can recognize the vector. If this happens, this antibody will destroy this vector before they reach the target cells. So, and this is, of course, decrease the chances or the efficacy of the treatment. Next, please. So to avoid that, most of the protocols, we will see that we exclude the patients, that when we evaluate if the patient has the anti-AAV vector antibody that we are using in that particular protocol, if it's positive, because of the not to compromise the efficacy, we tended to exclude this patient. This is a very important issue in terms of the eligibility to actually be able to receive the gene therapy. Next, please. The other immunogenicity related to the AAV vector is what we call innate immunity. That is the acute toxicity. In other words, are eventually some allergic reactions that can happen during the infusion or a few hours after. I may say that for the AAV vector, this doesn't mean a big problem once this many times is quite mild allergic reaction that few patients can have, and so far most of the time it's not difficult to control this kind of allergic reaction. Next, please. But what is a real challenge in this strategy is what we call adaptive immunity. This is related to a cytotoxic T-cell response. And to very briefly explain what's happening in this case is that when we infuse the vector targeting the hepatocytes, eventually, these hepatocytes that have been transduced, the hepatocytes that receive this viral vector, they can transiently express in their membrane some proteins from the vector capsid. This is transient, doesn't cause any problem in the hepatocytes. But when we infuse the vector, many times this vector can be also uptaken by the antigen-presenting cells. That is a very important cells from the immune system. And eventually, part of this vector can induce an immune response, actually a T-cell immune response. As we can see here, CD8 T-cell, that can, after this immune induction, what happens is they can recognize this capsid protein from the vector. And when the hepatocytes that have been transduced is expressing this protein from the capsid, this T cell can actually recognize this protein and destroy the hepatocytes. This is self-limited, doesn't cause any problem to the patient or to who is receiving the gene therapy. However, when the T cell destroys the hepatocytes with this transient expression of this protein from the capsid, we are destroying also the hepatocytes that was able to produce the factor VIII or factor IX. So in other words, we are losing the capacity or the ability to produce the endogenous factor VIII and factor IX, and many times the patient can lose, if not totally, partially the efficacy of the treatment. So next. So to avoid this immune response, many times we are using immunosuppression. And this is also something that's quite important to understand when we talk about gene therapy using this strategy, this adeno-associated virus, the AAV gene therapy. Next. So basically, thinking about this, the eligibility for the AAV-based gene therapy for hemophilia, so far, we are enrolled only adult patients with severe or moderate severe hemophilia AAV, at least less than 1 or 2% of endogenous factor VIII or IX, no previous history of inhibitor, and also patients that has no presence of anti-AAV antibodies or neutralizing antibodies anti-AAV vector that we are using in that particular protocol. Another issue that is very important is the patient must have a very good liver health. Next. So to understand why we are only enrolled the adult patients, and there is some limitations to use AAV liver-directed gene therapy for pediatric patients, we must know that when a child grows, also the liver also starts to grow. And this happens until this child achieves around 10 to 12 years of age. So during this period, the liver cells, the hepatocytes, are dividing quite frequently. And one thing that we needed to understand about the AAV vector, as we can see here, in the hepatocytes, in the nucleus, the transgene, the DNA containing the factor VIII or the factor IX, actually didn't are incorporated to the DNA of the target cells, of the host cells. So as we can see here, it shows as an episomal transgene. So when these cells will divide, one of the daughter cells will have this episomal transgene, the DNA that we introduce in the nucleus of these cells, but the other daughter cells will not have this episomal transgene. So with that, if we use the dose for a very young child and the liver cells start to multiply, what will happen is we will have a dilution effect of the cells that are now able to express the factor VIII or factor IX. And because of the anti-AAV that I have already explained, all the patients after receive the gene therapy with AAV vector actually produce a very huge titer, very high titer of anti-AAV vector. And so far, it's not possible to redose the same patient. So to avoid this problem and to decrease the efficacy, now we are not considered as the pediatric patients the best ones to receive AAV-mediated liver-directed gene therapy because of this dilution effect that can happen, and later on we will not be able to treat this patient again with using the same AAV. So next. So another very important eligibility criteria, of course, is the liver health. And we know that in our hemophilia population, it's not uncommon among the adults that they have previous infection with hepatitis B or hepatitis C. So this will not avoid these individuals to receive gene therapy, but of course, this needs to be controlled, and we cannot have active or chronic hepatitis C, for example, example. Also, the liver health, we now have other metabolic conditions previously known as NASH, the abuse of alcohol, and even comorbidities that sometimes makes the patient to use, for example, medications that can cause any liver toxicity. So this is all things that we needed to be able to be aware if the patient will be able to receive gene therapy targeting the liver cells. Next. So, okay, so let's talk about what we have and where we achieved now using the AAV, the ongoing clinical trials for hemophilia B. So we have ongoing 4 different programs for hemophilia B using this AAV vector. Next. One thing that's quite important that we needed to notice in all these trials and all the hemophilia B gene therapy trials are using the Padua, factor 9 Padua. Next, please. So to better understand, the factor 9 Padua was first described is a missense mutation in the factor 9 DNA. That was caused because of was first described in a family where a very young man had thrombosis, recurrent thrombosis. And when this patient was analyzed, he had actually this point mutation in the factor 9 gene. When this was evaluated, the conclusion was that the factor 9 Padua actually results and not in the increase of the amount of the factor 9 produced, but instead of that, with the same amount of the protein, what was observed is an 8-fold increase in what we call factor 9 specific activity. In other words, with the same amount of the protein, we have a protein that is way more potent in terms of its activity. So with that, we have, and this is perfect for gene therapy because producing the same amount of protein, we can have a protein that can give us much more factor 9 activity. That's what we are looking for and will control and give us the hemostasis that we are looking for. Next. So thinking about these 4 different programs, next, I would like to discuss with more details one of this program that is the most advanced one, that is the Unicure CSL variant program that we have the AMT-061 and the HOPE-B that is the phase 3 trial. Next. So the HOPE-B is the phase 3 trial enrolling hemophilia B patient that receive a single dose of AAV5 with the transgene factor 9 Padua at a dose of 2 × 10⁻13. So this drug is the etranacogene dezaparvovec. And as we can see, in terms of the inclusion criteria, all the patients enrolled in this phase 3 were adult with less than 2% of factor 9 and a good liver health. However, patients who have neutralizing antibodies, anti-AAV5, they were not excluded from the trial. And in terms of the immunosuppression, it was used reactively. It depends the levels of the ALT. So next. And this is quite important. In this phase 3, 54 patients received this drug, this AAV5 factor 9 Padua. And as we can see here, 21 of these patients, actually, they were positive for anti-AAV5, as it shows in red. And if we compare up to 2 years after they received this vector, we could see that there is no difference between the patients that were AAV5 negative or AAV5 neutralizing antibodies positive, showing for the first time actually that this was not something that avoid or compromise this patient to receive the gene therapy. And this is quite important because for this particular drug, using AAV5, patients that has the antibody anti-AAV5, they were not excluded. And this is very important in terms of the eligibility. Next. So recently, in last December, during the ASH meeting, it was presented the 3-year follow-up of these 54 patients from this phase 3. And as we can see, the mean factor IX activity is still quite the same, around 30–80%, the median 36%, and we had a decrease of more than 64% in terms of the total annualized bleeding rate, demonstrating a superiority to the prophylaxis that this patient were using before they received the gene therapy. And this is quite important. As we can see, durability is not an issue for this group of patients. Next. In terms of the safety of this phase 3, we had 9 out of 54 patients, 17% of the patients present with the ALT elevation, the transaminase elevation. That one of the common adverse events seen in gene therapy using AAV targeting the liver. All these patients, these 90 patients, receive corticosteroids with a mean duration of 70–90 days, and the factor IX expression was maintained. So it was considered that probably one of the causes of this ALT elevation was due to the immune response that was well controlled using prednisone. Also among this group, we have one death that was reported in a 75-year-old man due to cardiogenic shock, was not related to gene therapy. And another very important case that was reported, it was one case of hepatocellular carcinoma that a patient who was at that time 69 years old, after 1 year that he received the gene therapy, he was diagnosed with this very important cancer in the liver. But it's very important to note that this patient has other risk factors for hepatocellular carcinoma, as hepatitis B, hepatitis C, NASH, and also his age. So a very detailed evaluation of the cells that was taken from the tumor, it shows that there is no association of the gene therapy that the patient received with the diagnosis of this cancer. What is quite important, and this is one of the things that for the long-term safety, we needed to continue to follow. Next, please. So it's very important to say that this drug, now called Ngenix, was the first hemophilia B gene therapy approved by the FDA in November 2022. Also in February 2023, it was approved in Europe. And right now, it was also approved in UK. However, according to the NICE protocol, it's still not recommended as a treatment for the patients in UK. And in Canada, was approved in October last year. Next. But also in January, very recently this year, in 2024, another hemophilia B gene therapy was approved in Canada. And this is Beqvez, or fidanococogene elapaparvovec, that is now commercialized from Pfizer. And this is the second gene therapy for treatment of hemophilia B that we now have approved so far only in Canada. And this is actually a very good news that now we have 2 hemophilia B gene therapy approved in some place. Next. Okay, so in terms of the ongoing clinical trials of AAV-based gene therapy for hemophilia A, we can see that we have 6 programs that is still ongoing in different phases, including only phase 1 or 2 or advanced phase 3. Next. And for this presentation, I will be focusing the results of the BioMarine program using the BMN 270, that is the most advanced one. Next, please. So for GENERATE-1 is the phase 3 gene therapy using the valoctocogene roxaparvovec. That is also a AAV5 vector that has as the transgene the human factor VIII, B-domain deleted, that has the SQ linked, and this is the transgene that have been used for most of the gene therapy for hemophilia A, and it's the same that we already have one of the product in the market for several years, the B-domain deleted factor VIII, as a recombinant product that's in the market. So all patients in this phase 3 trial, they were adult with no previous history of factor VIII inhibitors. All the patients with anti-AAV5 was also excluded, and these patients received a single dose of 6 × 10^13 of the valoctocogene roxaparvovec, and as a primary efficacy endpoint, it was the change from baseline in the factor VIII activity. Next, please. So in total, 181 patients were screened. The most frequent screening failure was related to the presence of AAV antibodies. And in the end, in this phase 3, 134 patients were dosed, received the drug. 2 of these patients were previously HIV positive, and they received the treatment in the first phase of the trial, and one of the patients actually lost the expression, and later it was clarified that the reason why this patient didn't have a good efficacy of the treatment is because of one of the drug that he was using for the AAV treatment, that is the favirenz, causes some hepatotoxicity. So although now we know that to be HIV positive is not exclusion criteria, at this point, the patients were excluded just for this the continuation of this phase 3. So in total, we have as a modified intention to treat population or the HIV negative participants, 132 individuals, that is most of the numbers that I will show. And 112 patients were previously followed as a lead-in study, observational 6-month study to be evaluated in terms of the normalized bleeding rates. It's very important to also recognize here that one of the inclusion criteria, all patients were previously receiving prophylaxis with one of the factor VIII products. Next. As we can see here in this graph, in the first year, the mean factor VIII activity was around 43%. And here is all using the chromogenic substrate assay to measure the factor VIII activity. This is important because we also recognize that in all factor VIII gene therapy, we are seeing that there is a difference when we measure the factor VIII activity using one or another assay. So the most common assay is the one-stage assay, and based on ATTP. And if we are using this one-stage assay, the results are higher, around 1.6 times higher than the chromogenic assay. So the numbers that I will show here is the chromogenic assay. So in the first year, we are seeing that the mean was around 43%, but as it was observed in the phase 1 and 2 clinical trial with the same drug, there is a decrease between especially year 1 to year 2 in terms of the factor VIII activity. So for 43%, decreasing for 23%, and continues slightly to decrease in the year 3, around the 18% is the mean. And later this week, it will present also the year 4 of this 132 patients, and now the mean is around 16%, similar than the 17 patients that already completed 4 years when this was first presented. Next, please. Despite the decrease in terms of the factor VIII expression, we should recognize the clinical benefit of the patients who were involved in this clinical trial. So if we compare the baseline phase, where all patients were receiving prophylaxis with factor VIII concentrates, we are seeing that after these patients receive the gene therapy, these 112 patients received the gene therapy, there is a reduction around 83% of the bleeding, the ABR in these patients along these 3 years of evaluation. And again, if we compare the number of patients that had 0 bleeds in the baseline using the standard factor VIII prophylaxis, we had only 32% with 0 bleeds, but after they receive the gene therapy, we could see 82, 84, or even 75% in the year 3 had 0 bleeds after gene therapy. Next. So when this was presented, we had 17 out of the 134 patients, close to 13% of participants were returned to prophylaxis either with factor VIII or emicizumab. This all happened between the year 2 or after that. And I can just tell you that right now we have 24 patients out of 134. So the majority continues out of prophylaxis after the gene therapy. Next. In terms of the safety, the highest adverse event that was observed, it was the ALT elevation. We have 79% of the patients who had ALT elevation, and because of that, they received corticosteroids, and 60% of these patients actually had adverse events not directed to the drug of the gene therapy, but it was related to the use of corticosteroids. So we have one fatal event that was a suicide in a subject that had previous history of depression, and he never received immunosuppressant or corticosteroids after he received gene therapy. But another very important serious adverse event happened 3 years after gene therapy, where a young man, 24 years old, actually was diagnosed with B-ALL, so acute lymphoblastic leukemia, after 3 years of the gene therapy. And again, the whole genome sequencing of the blast cells showing that there is no integration that could relate this diagnosis of ALL with the gene therapy that the patient received. Next. So valoctocogene roxaparvovec, also known as Roctavian, was also approved as the first hemophilia A gene therapy, first in August 2022 in Europe, after in June 2023 by FDA, and very recently, early March, Anvisa in Brazil also approved Roctavian or valoctocogene roxaparvovec in Brazil, and this is probably the first gene therapy for hemophilia that was approved in Latin America, what is also a very important achievement. Next. Okay, so this is the summary of what we have from these clinical trials and what we learned so far from the hemophilia gene therapy. Next. Well, one thing that is quite important to recognize is that the variability of the response, and this happens in all hemophilia A and B clinical trials. Here, just to give you an example, the phase 3 that I just showed with 54 patients for hemophilia B, we could see that there are patients with quite low expression and some patients with very high expression. So there is this variability, and we cannot predict which one will have the high expression or the low expression. The same as happened to all the other hemophilia A gene therapy, and here is the example using the velocitocog gene roxapavovec. So this is one thing that is quite important, the variability and the unpredictability of the response. Next. And why this can happen? Well, here is some possibilities, some thoughts about that. Next. If we're thinking about the variability for the factor VIII expression, we need to recognize that for factor VIII, well, factor VIII is not producing the liver cells in the hepatocytes. It is actually producing the LSX, the endothelial sinusoidal cells, also from the liver, but in the endothelial cells. So it's not the same cells that is produced. We also have the interaction with VWF. We have the factor VIII secretion and the clearance mechanisms that is quite complex for the factor VIII synthesis. And this can be different between patient to patient. Next. But when we're thinking about the variability for either factor VIII or factor IX expression, there is some possibilities related to the transduction efficacy, resisting immunity, and other, even the vector manufacture or engineering, and also some patient-related risk factors, the liver health, the use of medication, the presence of comorbidities, and even unknown genetic factors. What I can say is so far, this is not clear. We don't know for sure which patient will have a good or low expression. Next, please. The other issue that I already touched with you is the durability. Well, and durability of the expression seems to be related only in the hemophilia A gene therapy for factor VIII. If you're seeing here in ASH December last year, it was presented the follow-up of the St. Jude, UCLA St. Jude clinical trial for hemophilia B. At that time, it was Dr. Amit Natawami, who presented the first, this new generation hemophilia B gene therapy. And this patient received the gene therapy for more than 10 years. And we could see here in blue that especially the patients who received the high dose, 2 times 10 to 12, and here is quite important to say that the factor IX here is not the factor IX Padua, is the white type. So these patients, since the beginning, they have around the 5% of the factor IX expression. And after 10 years, this continues to be quite the same, 4.9%. Of the expression up to 10 years, showing that there is a huge durability in terms of the factor IX expression for the patients who achieve this level. But for hemophilia A gene therapy, the longest clinical trial is the phase 1 and 2 of the velocitocog gene roxapavovec, and we could see that after 6 years, and here is only 7 patients, we had a decrease in terms of the factor VIII expression, similar than what I just showed in this first 3 years of the phase 3 patients. So there is a durability issue in terms of the factor VIII expression. Next, please. And what can cause this compromising the factor VIII expression? Well, this could be a target cell population, cell death. not only because of the immune response, liver toxicity, but one phenomenon that we call as cellular stress. Also, some things related to the vector properties, promoter silencing, or something related to the episomal, and the immune response that can also happen, as we already discussed in terms of the innate and adaptive immune response to AAV. Next. So, other few words about how to be prepared for gene therapy for hemophilia. Next. One thing that is important, and here I would like to share with you, next please, is our experience here at Unicamp. We now have 5 ongoing gene therapy clinical trials for hemophilia A and B, and very soon we'll have 2 other clinical trials that we are waiting to start. And so far we have 38 patients dosed in our center. Most of them, it was hemophilia A patients who received Veloctocog roxaparvovec, and 28 of the patients continues to follow the follow-up in our center. So here's just example of our pharmacists prepare the dose for a single patient, and some of the protocols is quite labor intense, and it's quite important to be prepared to follow and to also dose all the patients. Next. So what we needed to have from the institution for the hemophilia gene therapy. Next, please. Well, for sure we needed to have adequate infrastructure and the staff for each of the phase. Even to choose the patient, with the patient's selection and the shared decision making is quite important, because different than other treatments for hemophilia, this is not something that we can just stop if we don't want to follow anymore. Once the patient receives gene therapy, in terms of not only the efficacy, but also for the safety concerns, we need to follow these patients for a long time. For the gene therapy preparation, we needed to have infrastructure, and even for the gene therapy administration is a teamwork. We have several professionals involved. And after that, we need to be prepared not only for the short-term monitoring, and here we have the liver toxicity, the immunosuppression, the variability of the response, but also the long-term monitoring, because the durability and other safety and efficacy issues, all patients must know that once they receive gene therapy, even for the safety concern, we needed to follow them for the rest of their life to guarantee that there is nothing related to the long-term safety, for example, that can compromise these patients. Next. So in terms of the post-infusion monitoring, of course, when we talk about efficacy, it's not only the factor activity levels, but also the bleeding frequency, the control of the chronic pain, and how this impacting the quality of life of the patient. This is all important. Next. But also the safety issues, not only the short term, especially liver toxicity, the use of immunosuppression, and the long term as xenotoxicity and other developments that we can not even predict at this point, because we're still early in terms of the huge number of patients that were receiving gene therapy. Next. So a few words about how we monitoring the transient hepatotoxicity. And here we needed to very carefully evaluate the ALT levels. And one thing that's important, next, is to recognize that 80% of the hemophilia A patients who participate in the trials and 20% of the participants in the hemophilia B trials actually had ALT elevation. And this occurs especially in the first 26 weeks. So it's not uncommon, and actually it's very important that from the first 6 months, many times we needed to follow the ALT levels for 1-2 times per week, even 3 times per week in a very specific period if the patient starts to have the ALT elevation, because this became critical to, for example, decide if the patient must have immunosuppression at that time. So in the first year, we still have quite often needed to evaluate the ALT. And after that, we can actually measure the ALT levels 1 or 2 times per year. But during the first year, this can be more intense. Next. So the potential mechanisms that can explain the ALT elevation after gene therapy could be related to immune response, but could be related to other issues. For example, cellular stress that can be caused due to this unfolded protein, this new protein that the cell is producing, especially the factor VIII. This seems to be one of the cause, and other liver toxicity. Next. And of course, some of the patients must have immunosuppression based on corticosteroids, is the most common immunosuppression that we are using. Next, please. In terms of the immunosuppression, this could be reactive according to the levels of the ALT. Then we decided to start with the immunosuppression. This seems to be the most common trial to use. Or we can also consider to use prophylactic use of immunosuppression independent of the levels of the ALT. There is pros and cons in each of this strategy, but so far, even for the drugs that is already approved, the recommendation is to use reactive immunosuppression, reactive corticosteroids. Next. The other potential risk in terms of the safety is the transgene-related risk. Next. One could be the possibility to develop inhibitor to factor VIII or factor IX. So far, I can tell you that this was not reporting any of the patients who received gene therapy. And actually, for hemophilia A, we even have a quite successful trial that is an ongoing trial enrolling patients with previous history of inhibitor and even patients with current presence of inhibitor anti-factor VIII. And this makes sense because as we are thinking about the ITI, for example, the idea is to give a high dose of continuous factor VIII to induce immunotolerance. So in the case of the gene therapy, what we are doing is a continuous expression of factor VIII. So we can actually produce this immunotolerance. And this is a phase 2B trial that is being ongoing by BioMarin. And so far, the results are quite interesting. Next. And if in one side we are very key in terms of the efficacy and to have the expression of factor VIII and factor IX, we must remember that if the patient have overexpression of factor VIII or factor IX, now we are exposing this patient to increased risk of thrombose. And it was being reported one patient, hemophilia B patient, who had other risk factor for thrombosis, that when he was expressing a factor IX of more than 280% of factor IX activity, this patient actually developed thrombose. There is another case that from a hemophilia A trial that also have risk of developing a thrombose event. Most of this case, this overexpression is also associated to other thrombosis risk factor. And so eventually, in some periods, we should consider to use thromboprophylaxis for the patients with overexpression. And this is something that is also a transgene-related risk. Next. And finally, another safety issue is it's very important to follow each case of cancer that have been reported among patients who participate in gene therapy, no matter for what reason. And here I can share with you the cases that was reported of cancer in the patients receiving AAV gene therapy for hemophilia. We have a total of 6. So some of them, as you can see, happen in elderly patients, different kinds of cancer. And what it's very important to notice is most of them had other risk factors for this cancer to develop. And so far, none of this case was considering to be, the cancer diagnosis was considered to be related to the gene therapy that the patient to receive. Next, please. So to guarantee the long-term safety and efficacy, is very important that we have all the patients registry and follow, because eventually anything that can happen, and we must recognize that to take the action that is needed. And here I cannot end this presentation saying the importance of this international gene therapy registry that have been organized by WFH, and probably all the cases that receive gene therapy should be enrolled for all the years for us to follow the potential events that can happen to this population. Next, please. So in summary, I may say that gene therapy is now a reality. It's not only clinical trial. This became available for hemophilia A and hemophilia B, as I showed to you. So the most common adverse event as seen is ALT elevation, particularly in the first year. And eventually in the first 6 months, the patient must in some cases needed to use immunosuppression, and this can be also additional adverse events for this patient. And in terms of the long term, we must follow these patients to consider not only the durability, but the safety concerns. And the importance of to have a gene therapy registry is crucial to give us, you know, to evaluate the long-term safety. Next, please. I could not end this presentation, actually acknowledge the team here at the Unicamp from our Hemophilia Center, where I have amazing staff in all this multidisciplinary group that is really, really dedicated since 2019, when we have the first patient in this new generation of gene therapy, are very well dedicated to the patients that for the gene therapy, and of course for all the hemophilia patients that we are following here, that are so kind to see, you know, the possibilities to succeed and to advance in the treatment for them. So thank you very much for your attention.
Thank you very much, Dr. Ozelo. I think Antonio might be offline now. So it was really interesting and lots of information. I think we have all gotten a clearer idea of what gene therapy is and what the results have been so far. I invite all the people who are connected now to post their questions. We already have one question from Lucas, who he wants to know. Let me just check one thing. He wants to know if there have been any trials in women with hemophilia, and what the results have been.
Well, thank you very much, Lucas, for your question. This is actually a very important question. So far, no, none of the clinical trials, but I can guarantee for you that the new ones, the new generation, are discussing to enroll also women with hemophilia, and for the future, of course, for other disease when this develop, not to exclude the women from the gene therapy.
Great, wonderful. So of course there will be probably certain eligibility criteria to follow in that case, right?
Yes.
I was while we get a few more questions, I wanted to ask you. Okay, we have Karina here who says that she has a child with hemophilia B, but uh, uh, okay, so she has certain differences in the diagnosis. So apparently they were twins, and he was born with hemophilia B, but then they said that it was factor 8 rather than 9. So I'm not sure whether this was a question or not, but um, I was wondering what's the process when a person with hemophilia approaches you and wants to know about the whole process of gene therapy and whether it would be suitable for them or not. Uh, how do you go through that?
Well, this is a very important question. So first of all, we needed to guarantee that the patient understands what is the purpose of gene therapy and what it means to receive this kind of treatment. Because for years, for example, we can exchange new products, new concentrates, or even no factor treatments. And if there is any problem, we just stop the treatment and the effect is gone. But here is totally different. So we must guarantee that the patient understands what is about, because it's something that we cannot reverse. Once the patient receives the transgene, is there. Even if it's not working well, we are putting this patient in risk in terms of the adverse events. One thing that is a quite challenge, we cannot predict the outcomes. We cannot predict if the patient will have a good response or not. So some of the patients after gene therapy, the follow-up and everything that needs to be done, they didn't have a good efficacy, and eventually he needs to come back to the previous treatment. And in the top of that, even the patient is really a key and wants to receive the gene therapy. As I show, all the drugs, except the one that was approved for hemophilia B, the Ngenix, all the other ones, if they have the anti-AAV vector antibody, they are not a candidate anymore to receive this kind of gene therapy. So in this case, many times I had candidates that they wanted to receive. However, when the result comes, they were positive and they were excluded. What I can say to these patients, well, there is another alternative that is now this emerging next generation of gene therapy. Some of them not using AAV, are using gene editing, other vectors, or even other approaches. And maybe for these new advanced treatments, they will have some alternatives for the future.
Good. So that's good. Yeah, I think that the information, as much information as they can get, is very important because the process. How long does the process take, more or less?
Well, I will say here in our center, we have several visits before we have the final decision. Not only with the patient, but with the relatives, with the wife is the case, the mother, everyone, and to make sure that they understand. For example, one thing that is important is the liver health. And in terms of the liver health, the patient must avoid the abuse of alcohol. So it's recommended in the first year not to use any alcohol. And why? Because, of course, if you are drinking alcohol, any kind of alcohol, the ALT levels can increase. And we don't know if this was related to the alcohol that the patient had or it was related to gene therapy. But I may say to the patients, it's not only during the first year, even for the rest of their life, if they abuse from alcohol or any hepatotoxicity using a drug, for example, a medication, this can destroy some of the hepatocytes that were producing the factor 8 or factor 9, and the patient just lose the expression, and this can, gone. So this is very important. So the patient must to know that after gene therapy with this approach, they needed to take care of their liver for the rest of their life if they wanted to succeed with the gene therapy.
Good. One more question. We saw that you start, or the age to start this is 18 years old. And we also saw in the data that you shared that there were people with 69, 70 years old probably.
Yeah.
So is there an age limit
yeah, it's a good question. Actually, so now all the drugs that have been approved, the oldest that they recommend is 65 years of age as the max, and the youngest so far is 18. But I may say that some protocols are considering to enroll patients older than 12 years of age. I will say that younger than that, as I explained, this can be not the best approach. So maybe other alternatives of gene therapy for the future, but not for AAV direct to liver.
Good, wonderful. I've with a few more things here. Rosa from Dominican Republic is asking about the cost of the therapy nowadays. If there's at least an approximate, or her son has hemophilia A, so.
Okay, so the cost, of course, is high, but in each place they are discussing some possibilities in terms of the reimbursement. So as I showed, it was approved in Brazil. So they are discussing, for example, if this became part of our program from the Ministry of Health, some possibilities. For example, just to pay a risk sharing is one of the approach that you consider. If the patient succeeds, you pay one amount, and years or months later, you continue to pay if the patient continues to have expression. The other way is something that we can see, as I showed. Most of the patients didn't have bleeding and they are out of prophylaxis. So we know that although gene therapy is very expensive, the treatment for hemophilia is very expensive. So if we combine over the years, sometimes, this can pay the price. As I said, one of the challenges, we cannot predict the response. We cannot say for how long this will last. And if the governments and the manufacturers are discussing different approaches for the reimbursement, and this will be different in each place. So right now in US, in United States, there are some patients that received commercial gene therapy. So for hemophilia B and more recently hemophilia A. In Germany, there are, as far as I know, 3 patients that already received hemophilia A gene therapy commercially available. So each place are discussing the ways to reimburse, and the cost, of course, is high, but then needs to put in perspectives.
Right. Lucas, as a follow-up to his question about women with gene therapy, he asks whether there's a reason why there haven't been any trials in women yet.
Well, I will say, Lucas, one reason is because, women with hemophilia, they are not being treating properly for all these years. And it's not only gene therapy. Sometimes, even for other clinical trials, they were excluded. So I'm happy to say that now there is a huge movement to actually recognize women with bleeding disorders, including carriers from the factor 8 or factor 9 mutations that became, with the diagnosis of hemophilia, and even other ones. So there is no particular reason why they were excluded. Of course, in terms of pregnancy, there is several issues related to that. Even for the man, if the partner became pregnant, this can be a concern. concern. And one thing that I must say, that at least for the first year, because the vector can be found in the semen, it's also recommended to avoid pregnancy. And this is a very important issue also in gene therapy.
Good. Diogo from Brazil, he's really interested and he would like to have an appointment with you. So maybe we can share your contact later, or see. You are at University of Campinas, right?
Yeah, but the best way, Diogo, is to discuss with your the doctors that is following you, and then they contact us here at Unicamp, and we can see what we can help you.
Perfect. And Karina, who was talking about her child, he's a 9-year-old child, so I guess he can't have access to the treatment yet until he turns 18, right?
Yes, well, what I showed to you as a 9-year-old boy, this is not something that is the best option. Soon, I think some other strategies will also enroll children with hemophilia. So using different vectors, different approaches, then the age will not be a barrier, as I showed here so far.
Perfect. I have one more question. Are there any comorbidities that could affect the treatment apart from liver, the state of the liver?
Well, the comorbidities, I think the most important ones is related to the liver health, but also the comorbidities that actually need to use some medications that can cause hepatotoxicity. For example, I had one patient who had some anxiety, and because of the psychiatrist drugs that he used, causes some possibilities of hepatotoxicity. We didn't consider him as a good candidate because of that. So, there are things that we needed to put in balance. And because we cannot predict the overexpression, as I showed, we must be concerned with the patients with also high risk of thrombosis if they have overexpression. We have several patients in these clinical trials that had, for example, 300% of factor 8 or factor 9. Some of them was transient, some of them continues after years. So there are patients that after the gene therapy, they are using thrombotic drugs. So this is something that we needed to be also concerned.
Good. And in the case of the durability that you were talking about, if there comes to an end the results of the therapy, can the patient go back to the prophylactic treatment that they were having before? Or
yeah, sure.
Yeah.
So they can go back to what they are having before. There are several patients, for example, from the Hemophilia A that exchange to emicizumab, and before they are using any kind of factor 8 concentrate. This is not the concern. The only thing that I may say that even if they are back to the prophylaxis and we consider that the efficacy was limited or they lost the efficacy, the safety issues needed to be followed. So this patient should, have at least once a year the liver examination with ultrasound and other ways to guarantee that there is no concerns in terms of the liver health, for example.
Great, perfect. Is there anything else that you would like to add that we haven't asked, or that you consider that should be shared?
Well, I think what is important to say is even here in Latin America, we could show and we could see that gene therapy and other advanced treatments can be a reality. And I think it's time for us to organize the centers and to thinking about for, the best candidates. Gene therapy is not for all patients. This is very important. This is one of the alternatives for some specific patients. And there are patients that will really benefit, and it's a chance for try. Not all of them. So, and the pros and cons needed to be discussed with each patient. There is a very good tool now from WFH, and I know that is also in Spanish, that is the shared decision-making tool. In this tool is quite good for the patients with their doctors and the healthcare providers to go through each question, and the gene therapy is there and can also help when comes the decision if for that patient gene therapy could be alternative or not.
Perfect. Dr. Ozelo, thank you so much for this presentation. I think you've been very thorough in all the information that you've given us. Thank you to all of the people who joined us. We started with just a few, but we are 28, 30 now. So it's been really successful, and I think people are really interested in the topic. Thank you to Isidro, who's managing all the technologies behind screen, and to Antonio and all the coordinators and everyone who has joined us. Thank you so much. Thank you also to the interpreters who have been working all along. And well, I think this is time to wrap up. I'm sure we are probably going to see more of you and later on in the year. I guess we are going to meet at the Congress as well. So it's been great to meet you, and thank you to everyone. Muchas gracias a todos por unirse, y bueno, esperemos que les haya gustado.
Thank you very much. Muchas gracias.